Uh, so today, as he said, we are going to discuss what's new in RCC management because all of us as an oncologist, we know that as of now, a few days back, few months back, few years back, there was a standard tablets we were having called sunitinib, pazopanib, and then in the second line exitinib. So we were having only two, three options. And apart from that, there was a bevacizumab in combination with some VEGF inhibitor. So there were two, three or four options, but mostly we were using either pazopanib if patient is not affording, and then sunitinib if patient is affording, because that was the original one and that cost a lot, more than I think 2 lakh rupees or so. So, but surprisingly, last 1 year, that till the time last 1 or 2 year, I would say, this immune checkpoint inhibitor has come. So no one is discussing even about sunitinib. So even options NCCN has given down the line, and immune checkpoint inhibitor combination has come upfront, category one, and the trials which we are going to discuss today, they have been comparator arm is always sunitinib. So that means that even all the immune checkpoint inhibitor trials or researchers have taken sunitinib as a standard of care. So my only saying by these things are that we have availability of sunitinib in the generic form. In fact, we can try sunitinib in the generic form if patient is not affording, because we have been using sunitinib for quite long time, more than 10 years, 15 years, which is showing very good result. And of course, there are some side effects, but it was manageable in around I would say 70 to 80% patients. So sunitinib was a good drug, is a good drug, and I think we should explore at some point of time if patient is not affording for immune checkpoint inhibitor. So today's we are going to discuss 2-3 trial which was published, which was presented in Asco 2020 in 2-3 forms separately. And first trial which we are going to discuss is about pembrolizumab, which was discussed in this May 2020, and that was keynote 426. So that was phase 3 trial about this combination pembrolizumab plus exitinib, as compared to, as I said, versus sunitinib, which was the comparator arm, and this was the updated analysis. So some successful trial, phase 3 trial, if they have in analysis at some point of time, we call it as interim analysis, then updated analysis at 2 year, 3 year, 4 year. So I believe every year they will come out with the updated analysis in ASCO or ESMO. So we will going to discuss pembrolizumab as well as later on nivolumab also. So before that we were using exitinib as a second line, and believe me, this was not showing very good result. Response rate was also very poor. It was hardly, I think, 10 to 20% response rate with the single agent exitinib in the second line or third line after 2 or 3 VEGF inhibitor failure. So, but with the combination of pembrolizumab, they are showing very good result in terms of every outcome. So in the background, first interim analysis of this trial was published when patients were on follow-up 7 months down the line, and they have shown very significant efficacy in terms of overall survival, progression-free survival, and overall response rate, as I said, in all the 3 parameters, and all the patients were treatment naive. So they were upfront metastatic clear cell RCC in favorable and unfavorable risk category in both on all the 3 categories as per the IMDC. So overall response rate, good hazard ratio 0.53, p-value was quite significant. PFS was also good. Overall response rate roughly around 60%. So all these results, even after 7 months follow-up, they have got approval as a first line for advanced RCC, and it has come into the NCCN also as a category 1. So pembrolizumab plus exitinib. Currently, we are going to discuss the updated analysis, which is 2 years down the line. So minimum follow-up period was 23 months of the same trial, keynote 426. So this was the schema of the trial. It was a randomized open label phase 3 trial, and it was stratified by IMDC risk group, favorable, intermediate or poor. And reason they have taken North America versus Western Europe and versus rest of the world. So I don't know whether India was part of that trial or not. I have to check. But basically patients with newly diagnosed recurrent stage 4 clear cell RCC were taken with measurable disease, no prior systemic therapy for advanced disease, and good number of patients were there, 861. And 50-50 patients almost were divided in two arms. One was the comparator standard of care at that time was sunitinib. In the standard doses, 50 milligram once a day for first 4 weeks out of 6-week cycle. And second experimental arm was pembrolizumab, 200 milligram 3-weekly interval for around 2 years up to 35 cycles. That comes around at a 2-year period, plus axitinib for 5 milligram per oral twice a day. Here, I'm not sure whether axitinib was also for 2 years for 35 cycle and continued beyond that as a single agent. I have to check in the full paper article. So I don't know about that. Yeah, pembrolizumab was given for 2 years only, 35 cycles. So primary endpoint was OS and PFS. Secondary was overall response rate, duration of response, and safety. Data cutoff was 6 January 2020. Until that time, around 1/4 patient were continuing on this experimental drug, 22.8% with pembro plus axitinib, as compared to 17% with the sunitinib. So roughly 70% patient were discontinued due to progression in the pembro arm and 80% in the sunitinib arm. So this was all about distribution of this was a randomization. So regarding distribution of these two comparator arm, median age was more than 60 in both arm. Male roughly 70%, 74%. Maybe this disease has male preponderance, and rest of the world was 50% of the cases, and in both arm, favorable, intermediate, and poor patients who are this category patient were taken, and they were also well balanced in two arms. More than equal to 2 metastatic sites were taken into account. That was 72%. Previous nephrectomy, 83% in both arms. Sarcomatoid features were there in roughly around 20% patients. And PDL1 CPS score more than equal to 1 was in 60% of the patient both arms. So controversial thing over here is nephrectomy. So with the availability of so many VEGF inhibitor or immune checkpoint inhibitor, the question of nephrectomy is in doubt, and it is a controversial topic nowadays, whether we should go for nephrectomy or not, because it doesn't make sense if you are going for immune checkpoint inhibitor. So unless until patient has symptomatic lot of hematuria or major bulk of the disease, systemic disease in the kidney. So there are 1 or 2 indication only for nephrectomy nowadays. But yeah, this trial must have conducted since long. So 83% patient must have on previous nephrectomy. So subsequent after this treatment, what they have received when they discontinued this treatment. So roughly around 54% in this arm and 69 in sunitinib have received some treatment. Any PD1, PDL1 inhibitor, 8% in this immune checkpoint inhibitor and 50% in the sunitinib arms as a second line. So very surprisingly that once patient has been exposed to pembrolizumab, 8% still they were given option of PD1, PDL1 inhibitor, because but yeah, second line PDL1 inhibitor is not recommended after failure of immune checkpoint inhibitor. So any VEGF inhibitor were given in 50% patient in pembro arm and 45 in sunitinib. So after this 2-year updated analysis, we can see at 1 year overall survival. So overall survival at 1 year, 80% patients in the sunitinib arm were surviving at 1 year. So as compared to 90% in the experimental arm. So there was around 10% difference, and this difference was being maintained at 2 year also. So roughly 66% versus 74%. So again, roughly 10% difference at 2 years. And if we see the curve, both curves are still separated and equidistant even after 3 years. So at 36 months, we can analyze, we can see curves are still separated. That difference, benefit of this pembrolizumab axitinib is being maintained even at 3 years or even beyond. So I think later updated analysis will come. But at 2 years, definitely there is a difference with good hazard ratio. And if you see the progression-free survival, Again, at 2 year, 27% progression-free survival as compared to 38% in pembro arm. So this analysis were published last year only in Asco. So as per this analysis, if we see the overall response rate, 60% was the response rate with pembro combination as compared to 40% with the sunitinib. So 20% difference in the response rate was also seen, in which there was good amount of CR also. Roughly around 9% patient had complete response in pembro combination as compared to 3% in sunitinib. So huge difference as compared to sunitinib. Therefore, this must have been the standard of care nowadays, pembrolizumab plus axitinib. Partial response was also better. Stable disease was also 23%. And progressive disease was only 11% as compared to 17% with sunitinib. So these were a very good result. And if you see the outcome as in favorable risk or unfavorable differently, in favorable risk group, as per the IMDC, outcome was not very superior. So OS was in fact slightly inferior or almost similar. And response rate was also there, but these are not very good as we see in the intermediate and poor risk group. So response was better in intermediate and poor risk group in terms of OS, PFS and overall response rate. So difference, we can see that it is more than 10% in OS if we see at 2 year, or if you see PFS at 2 year, 23%, 34% in patients with intermediate or poor risk group as per the IMDC. Even overall response rate is also good and good CR, 8% CR in the poor risk category. So whenever any patient of metastatic clear cell RCC comes to us with intermediate or poor risk category, so definitely this has an edge over and above sunitinib, because in this group we were having one drug that is called, I think, temsirolimus. So you should know a little bit about temsirolimus also. That was injectable, very toxic drug, very myelosuppression was there, and in fact we have used only few patients, 2-3 patients, and then I think this was withdrawn from the market. It's only theoretical nowadays. That is called injectable temsirolimus in poor risk category. But with the availability of this data, I think for poor risk, this is the key and best combination to use. If we talk about treatment-related adverse event of incidence more than 20 or equal to 20 in either arm, so this bar chart in light shaded and dark shaded blue is showing very good representation of side effects. Diarrhea was the most common, and I think hypertension was the most common, and then diarrhea was seen. Palmoplantar erythrodysesthesia was seen. I think all these side effects which is seen on the pembro combination, mostly these side effects are due to the axitinib part. So I think these are not due to the pembro as such. And on the other hand, sunitinib has also got the side effect of hypertension, diarrhea, and palmoplantar dysesthesia, fatigue, nausea, liver enzyme alteration. We have seen all these side effects in sunitinib arm, and thrombocytopenia, which is very cumbersome sometimes, and we have to reduce the dose of sunitinib. And neutropenia is also seen in sunitinib. So sunitinib was tough drug to handle, but yeah, we have managed somehow. It was really tough. I think pembro and axitinib is more easier to use in terms of less side effect and better efficacy. If we talk about adverse event of special interest, like all the adverse event related to the immunological mechanism of action, like hypothyroidism, pneumonitis, adrenal insufficiency, colitis, thyroiditis, hepatitis. So all these side effects, if you see these graphs, these are written only but not seen in pembro combination, except I think grade 3 or 5 they have shown thyroiditis as well as thyroiditis, colitis and adrenal. So these 3 side effects are seen in grade 3 or 5 with the pembro combination. So we should be aware of these 3-4 combination side effects: thyroiditis, colitis, and I said adrenal insufficiency. And we should know how to manage these side effects when any patient is on pembrolizumab. So findings from this phase 3 trial was also supported by the long-term data from phase 1b study also, which was small study, and 52 patients were taken in that study Only I don't know why, because they have come with the follow-up of that study also during the same period by Atkin et al. In Asco 2020. So these results have also superimposed the Keynote 426 data with similar sort of outcome in median OS, median PFS, duration of response, and side effect profile. So all these outcomes in phase 1B study is also comparable to the Keynote 426 final analysis. To conclude about this particular trial, this combination of pembro plus axitinib continues to demonstrate significant improvement in efficacy as compared to sunitinib in treatment-naive patients with advanced RCC based on longer follow-up of 23 months of minimum follow-up. For OS, we know good hazard ratio, PFS good with quite significant p-value, and up to 60% overall response rate, out of which 9% is the complete response, complete remission. So patients with IMDC favorable risk showed no difference in OS with this combination. However, with intermediate and poor risk showed superior OS with pembro combination as compared to sunitinib. So investigators of this trial concluded that these results continue to support this pembro axitinib combination as a standard of care for patients with previously untreated advanced RCC. So after conclusion of this trial, I would just add one more point that I think newer data is also has come this year, 2021. I'm not remembering the trial name as such, but yes, pembrolizumab along with lenvatinib. So this combination is also approved. And as per the trial, I think side effect profile of pembrolizumab and lenvatinib is lesser, and efficacy wise also it may be slightly superior to this combination. So pembrolizumab plus lenvatinib is also approved as per the latest data in 2021, although I'm not having that trial right now. So next topic of discussion in the ASCO 2020 was immunogenomic determinant of response and survival to PD-L1 blockade in advanced clear cell RCC. Because today only I was discussing with my DNB, Sachin knows that I was saying that some PD-L1 or PD-1 inhibitor are working beautifully in some patient and not working at all in some patient. So there might be some markers, predictive markers beyond PD-L1, which can predict that it is going to work or not. So this data will throw some light on that point, predictive markers. So blockade of PD-1 pathway with immune checkpoint inhibitor has transformed the treatment of clear cell RCC. Only a subset of patients responds to PD-L1 blockade. So underscoring the need for some predictive biomarker, as I said. So data suggests that predictors of response to IC immune checkpoint inhibitor in clear cell RCC may not align with typical correlates. So clear cell RCC features modest tumor mutation burden TMB, theoretically limiting the number of neoantigens recognized by cytotoxic T cells, or high infiltration of cytotoxic T cell in clear cell RCC is also linked to poor prognosis. So there are some data supporting this study, these thoughts. And current study explored the immunogenomic determinants of therapeutic response and survival. So they analyzed Braun et al. And 592 tumors from patients in checkpoint all three trials 009, 010, 025. Out of these three trials, 362 patients were treated with nivolumab and 230 with everolimus as a control arm on Checkmate 025. So tumor sample was subjective to whole genome sequencing, RNA sequencing, and all these molecular analysis to identify immunogenomic determinant. And correlation was analyzed by stats method. So there was no association between the number of somatic alteration and response to anti-PD-1 treatment according to 4 different measures. All these points. So one point was that there was no association between the number of somatic alteration and outcome. Second point, PBRM1. So this is one mutation that is called PBRM1 mutation, which was associated with improved response and prolonged survival with anti-PD-1 treatment. We can see that on the vertical side, there are proportion of patients with PBRM1 loss of function mutation, and these are showing the clinical benefit. Blue bar is showing the clinical benefit. So we can see that clinical benefit was more in those patients where this mutation is found as compared to where this mutation is not found. So clinical benefit was here defined as progression-free survival more than 6 months, CR/PR. So anti-PD-1 treatment, we can see that light blue as compared to purple. So light blue is PBRM1 loss of function, which was showing better result as compared to wild type in PFS. In OS is still cover more separated. So outcome with the PD-1 inhibitor is much better with loss of function in PBRM1 with this particular mutation, but no difference with the mTOR inhibition. So I think that is one particular marker which can be explored in later period of time with all the previously published trial. Another point was Cd8 T cell infiltration. Although advanced clear cell RCC have highly infiltrated by Cd8 T cell, but still this infiltration is not associated with response or survival with anti-PD-1 treatment. So in all the in these trials, they found that response was similar irrespective of Cd8 T cell infiltration. Another positive finding was this one. So one was PBRM1 mutation, another was del9p21.3 enrichment. So tumor infiltrated by CD8 plus T cell show low enrichment for PBRM1 mutation, but high enrichment for multiple copy number alteration, that is del9p21.3. Means these subsets were those where PBRM1 mutation was not found, but this particular alteration was seen. So with this particular alteration, we can see that only del this copy number alteration is a poor response and survival with anti-PD-1 treatment. So this one was the negative predictive marker. del9p21.3 enrichment can be taken as a negative predictive marker to PD-1 inhibitions. So that is the outcome which is reflected in these graphs, PFS and overall survival. So to conclude about this trial, all these 4 points which I said right now. Another point, advanced clear cell RCC show high CD8 T cell infiltration, which is associated with depletion of PBRM1 mutation and enrichment of del9p21.3. So these are mutually exclusive. Investigation proposed that potential interplay of somatic alteration and immune infiltration in these type may modulate the response to PD-1 blockade, laying the groundwork for future investigation. So these were 2 trials. Now we are going to discuss the next trial, which was published in 2020 Genitourinary Cancer Symposium. I will skip this fastly through this trial because this is very experimental drug, but mechanism of action is very unique, in the sense very different. We know the pathway of this clear cell RCC. We have gone through 1/2 mutation in the tumor suppression gene, which is VHL, von Hippel-Lindau gene, encoding pathogenic VHL, and this deficiency leads to constitutive activation of one transcription factor, that is HIF2 alpha, which is a renal oncoprotein. So this investigation drug is selective for this particular at this particular point and inhibitor to this HIF2 alpha. So drug name is MK6482, and this is dose finding study, a very initial study, phase 1 or 2 trial. 120 mg once a day was taken until progressive disease or toxicity. Demographic profile was well balanced in all the different category, and median follow-up was 13 months. And outcome of this trial was taken as a safety. This is I think previous 71% patient have discontinued this trial, and 30% were continuing at the follow-up. And most common reason of discontinuation was progressive disease. Side effect profile, we see there are 65% patients, 65 had grade 3 to 5. Side effect profile is too high. 4%, and there were cardiac arrest, hypercalcemia, respiratory failure, sepsis. So this is too early to discuss this particular drug, although they were very initial studies for dose finding. I would skip this. Yeah. So now last trial we are going to discuss about nivolumab plus ipilimumab. Update of first line, and this is the Checkmate 214. This was the landmark trial for approval of this combination, and they have come up with the update at around 3.5 years, 42 months. Here again, comparator arm was sunitinib. So initial analysis of this Checkmate 214 showed intermediate or poor risk with advanced RCC treated with nivo-epi combination, improved median overall survival and overall response rate compared with those with sunitinib. So median OS was also better, overall response rate PFS at the interim analysis. Now we'll call it interim or initial analysis, and based on which in 2018 they got the approval for this combination. Now we are going to discuss the follow-up updated analysis of this trial at 42 months, which was published even in Lancet Oncology and presented at Asco GU at last year. So it was phase 3 trial, well balanced, good randomization as in previous trial. Treatment naive patient were taken. Performance status more than or equal to 70 kps, and tumor tissue was available for PDL1 testing. So standard sunitinib, experimental nivo-EP in standard doses followed by, so they have given combination around 4 doses, and we must notice that ipilimumab dose is also low, 1 milligram per kilogram, because it is highly toxic drug. 4 doses and then followed by nivo maintenance at 2 weekly interval, and it was continued till progression. So here it is not up to 2 years. With pembro we have data up to 2 years, so limited duration of time. That is one advantage with pembrolizumab combination. So primary endpoint here is over the same or response rate PFS. Secondary was the response rate in the intention to treat population safety profile. So baseline characteristic, favorable risk was seen in intention to treat population as a secondary analysis. Poor risk category was there in 20% all throughout, and intermediate was also seen in 80% patient. Rest of the world patient were 40% in this trial. Updated OS even at 4 years. This is remarkably good difference. 40% with the sunitinib and 52% with the nivo-EP at 42 months. So roughly around 12% difference is still there at 4 years. So, and curves we can see it's still separated after 4 years, and its difference is still continuing even beyond that. So minimum follow-up period at 3 point of time they have published at 17.5 months, 30 months. Now final analysis at which was published last year, which is 42 months, and they have shown that OS roughly over median overall survival is 47 months as compared to 26 months with the sunitinib. So median OS with sunitinib was 2 years, and median OS with nivo-EP is 47 months. Huge difference. So around 4 year median OS is unbelievable data. Maybe obviously they have taken all the, I think, second line or third line on progression. So updated OS in intention to treat population also, it's being maintained. And favorable risk, although not much difference, so almost similar as we have seen in the pembro trial. But yeah, intermediate and poor risk are showing better difference in these two arms. So durability of CR was also, complete response was also better with this combination of nivo-EP. And if you see the progression-free survival at 42 months is almost doubled, 19% with the sunitinib, 35% with the nivo-EP. So they have analyzed with the intention to treat population also. This difference is being maintained. Favorable risk, not much difference. And regarding treatment-related adverse event, more or less these are similar also with any immune checkpoint inhibitor. All the treatment-related adverse event which we have seen with the previous trial. With sunitinib, we know that hypertension, diarrhea, dysesthesia, fatigue, anemia, neutropenia are all there with sunitinib. So conclusion of this Checkmate 214, long-term follow-up of this trial confirmed improved OS and overall response rate with nivo-EP versus sunitinib in intermediate, poor risk and intention to treat population. Both intermediate and poor risk and intention to treat patient population experienced PFS curve plateau at 35% after 30 months with this experimental drug combination. And for favorable risk, efficacy data favored use of sunitinib versus nivo-EP. So we can say somehow that favorable risk still we can use sunitinib. Sorry. Incidence of treatment-related adverse event, treatment-related select adverse event and corticosteroid use decreased over time and no new safety signal observed with new OAP. So discontinuation was due to treatment-related adverse event, and they did not affect the OS overall survival. So thank you overall. So these were the new data about RCC, which were worth noticing. Thank you.